Okay, so we will begin. Good evening, everyone, and welcome to a very special lecture series for Home on the Hill Supportive Housing. It is so great to see so many people gathered here at the Richmond Hill Center for Performing Arts for our lecture. My name is Angelo Minardi, and I am a board member for Home on the Hill, and it is my pleasure to once again welcome you and act as our Master of Ceremony for the evening. Before we introduce our speaker, Susan, after a lengthy introduction, I would like to first take a minute to introduce to you Dr. Ivan Silver.
It's nice to be introduced as a geriatric psychiatrist because last year I became a geriatric psychiatrist. I'm collecting a pension now. So I'm very happy to be here and to come north to Richmond Hill and to have been invited by Home on the Hill. I've taken a good look at the website and I'm so impressed because I completely identify with your mission around housing for the mentally ill, one of the most vital needs I can think of today and one of the most missing needs everywhere. So I'm excited about your goal to provide new housing right here in Richmond Hill for your clients and patients and to support your families. Before I introduce Susan, Kathy actually asked me to say a few words about what CAMH is doing to support families and to engage families. We've embarked on a new integrated approach to family engagement. It's anchored in our clinical programs. Our new family engagement office will work closely with these programs to ensure family engagement right at the point of care and with service planning, something we felt has been missing for many years. The office will be linked to my office, the one that I run in education, and to communications and partnerships so that we can enhance education programs for families and collaborate with other family groups across Ontario to advocate for families, including your group. This new office will provide a center-wide focus on family engagement to improve integration, tracking, evaluation of the activities, and assure alignment with our clinical priorities. We're going to create an advisory council that will include representation of families as the key component. And we're looking at digital approaches to expand our reach beyond our own organization. So now to Susan. So I first became aware of her through my relationship with David Goldblum, who was the former president of the Canadian Mental Health Commission. And when we were looking for a person who could speak on behalf of families for our new national board that is advising our portal, our web portal called Portico, Susan was the name that emerged, and she was a name that emerged nationally, so someone who could really speak to the needs of families, particularly of families with loved ones with serious mental illness. So Portico is a new web portal. We just opened it officially last year. If you want to take a look at it, it is porticonetwork.ca. And it's primarily targeting the education of primary care physicians and nurse practitioners, but increasingly patients, clients, and families, to really help educate care providers on the latest advances in mental health care and addiction assessment and treatment. Susan has been very active on this board. I just met her actually tonight in real life because I've been speaking to her on a video conference for the last 3 years. She is by far our most active member of our board, our most active participant, passionately, I want to tell you, advocating for the inclusion of the latest approaches for treating our most serious of mental disorders, the psychotic disorders, and particularly schizophrenia. Susan received her BA from Swarthmore and her MA from UCLA, and she's a recently retired high school teacher, she tells me. I knew you were a high school teacher, but I didn't know you were retired now. And following the onset of her younger daughter's catastrophic schizoaffective disorder, Susan began to write about serious mental illness for a variety of Canadian publications. Her memoir, which I guess you're selling tonight as well, After Her Brain Broke, Helping My Daughter Recover Her Sanity, was published in 2010 and has received worldwide press coverage and uptake by diverse audiences, including the National Alliance on Mental Health in the United States and the European Federation of Associations of Families of People with Mental Illness, and numerous other Canadian organizations, including the Mood Disorders Society of Canada, the Mental Health Commission of Canada. Susan speaks publicly in a large variety of events, both large in size and small, and really emphasizing the situations that families face in helping to care for a family living with a serious mental illness. She's the past president of the British Columbia Schizophrenia Society's Vancouver Richmond Hill branch and a past vice chair of the Vancouver Coastal Health Family Advisory Committee. What she may even be best known for, if you're online and read the Canadian Huffington Post, is her monthly column on vital and urgent issues in mental health care. In the past 4 years, Susan, among many other topics as well, has addressed these important issues. The role of families, caregiver issues, mental health policies, peer support health work training, mental health literacy, the need for science-based practice of psychiatry, unmasking the myths of mental health, the importance of medication, and cognitive remediation for treating schizophrenia. Susan's approach is to address elephants that are in the room, to challenge, to debate, to argue, to raise issues, not always comfortable, that need to be addressed. And ultimately, she's one amazing advocate for the mentally ill, and especially for families coping with serious mental illness. In 2013, she was recognized by the Queen Elizabeth II Diamond Jubilee Medal, which goes to people who provided an opportunity to honor exceptional Canadians for their contributions to their fellow citizens, to their communities, and to their country. And that's Susan. That's exactly what she's done. So I'm very pleased and honored to invite you now to deliver your talk, What Families Need for the Mental Health System. Susan.
I want to thank Richmond Hill's Home on the Hill family group for inviting me here tonight. Because I am in constant communication, basically, with Kathleen Mokanaki, I think that what you're creating here really can be a model for the rest of the country. We don't have a group like yours in British Columbia. I don't know if something else exists someplace else in Canada. I certainly haven't heard of it. I think this is tremendously exciting. In that book, I want to give a little more attention to Marvin Ross, my publisher, and I know that he's come to speak to you, but I just want to make sure that people understand the crucial role that he plays, not just in Canada, but in the U.S. as well, in giving a voice to people dealing with the most severe mental illnesses. 2 women in Vancouver who have lived with schizophrenia for a long time have written memoirs. They approached Marvin, Sandra Ewan McKay, Aaron Hawks, and he helped them shape their books and bring them to publication. They've both done very well. And Aaron Hawks, in fact, I urge you to Google her with Huffington Post, because she provides a viewpoint that we're not hearing enough about, and it really is there. This is people with severe psychotic disorders who basically say what Aaron says very articulately. Thank you for providing me with involuntary treatment. I was too ill to know that I needed treatment and I would be dead without it. So Marvin has played a key role in getting that voice and that message out to the Canadian public. I know about Home on the Hill because of Kathy and because Marvin Ross has talked about it. And because of them, and only because of them, I know about the tragedies that you have confronted this year. The absolutely horrifying, terrible tragedies that were not inevitable. And I did want to tell you some context for my hearing about them. I really only learned about them through Kathy in email, and Marvin blogged about Robert Veltier's situation for Huffington Post. I urge you to read this blog if you haven't. I wouldn't have heard about it because it really didn't get much coverage nationally. And there's only about 500 murders a year in Canada. But we didn't hear much about this in British Columbia, in Vancouver. I thought maybe it was just me, but maybe I was preoccupied, and I talked to various friends who assiduously keep up with the news. But in general, unfortunately, I think this situation was underreported. And I think that there are some reasons for it. I think many journalists in Canada, because of some current social trends, and I'm going to put many elephants in our room tonight, some of these social trends have led some journalists to believe that you really shouldn't talk about anything negative associated with mental illness because it will create stigma. Some of us believe that untreated mental illness is the big problem, and the actions that occur from untreated and undertreated mental illness, those are the actions that create stigma. And it doesn't help anybody to ignore what circumstances produced these frightening occurrences for what should be treatable disorders. So I am concerned about the lack of appropriate journalistic coverage of illnesses that are of concern to us. And some of you already know, I hope, about the Treatment Advocacy Center in the US, started by, I think, the most helpful psychiatrist for our population, Dr. E. Fuller Torrey, the author of Surviving Schizophrenia. This has become the hub of useful information about the neglected, severely mentally ill in the US. It's become the hub of information about how there are 10 times as many people with severe mental illnesses who are now incarcerated as there are remaining acute psychiatric beds. The treatment advocacy has called attention to these problems again and again when many people would like us to look elsewhere. And in fact, last week, some key movement has been made in the US Congress. I'm going to be getting to these politics because they impact us in Canada. So the Treatment Advocacy Center has a new publication that I just got to preview before Marvin picked me up, and it will be made available to the public, and I'll send it to Kathy right away. But I thought that it would be of interest to you. Its latest research project is called Raising Cain, the Role of Serious Mental Illness in Family Homicides. So a very much needed attention on this topic. Kathy has let me know that she has great interest in something that I think really needs to happen here, that the Treatment Advocacy Center does nationwide in the US. Kathy wants to start a registry of preventable tragedies. We need to be keeping track of these because otherwise they easily disappear, and we also don't probe what are the policies that led to these things happening. So I sure hope she experiences great success with this, and I've now approached the BC Schizophrenia Society, my partner in many things, to share this idea that I hadn't thought of for us till she brought it onto the horizon. It's really a great privilege for me to be here with you all tonight as the family caregiver of somebody living with a very significant mental illness. And I will talk about my daughter's situation later. just a preview. She's lovely. She has amazing acceptance of her illness because she had high-quality psychoeducation, she and her friends, which has led to years of stability, because she had access to involuntary treatment when she needed it and never wants to be left in the future in untreated psychosis, and because she's had a very collaborative psychiatrist. However, my daughter, like many people with schizophrenia and some other psychotic disorders, is profoundly disabled because of predictable cognitive losses, and I'm going to be talking about these with you more. So what do we need from the mental health system? I'm going to be talking about what we need, what we have instead, why we don't have what's needed, and how we can work to get what's needed. What we need is really simple. We need state-of-the-art, evidence-based psychiatric and psychosocial rehabilitation services. We need collaborative relationships between mental health professionals and families who really do provide the bulk of care for people with the most severe mental illnesses. Unlike other family caregivers, and there are more and more because we do have more and more of the population aging, the baby boomers having to confront dementia and Alzheimer's, and their families having to confront becoming family caregivers. What I see in British Columbia is great interest, which we taxpayers need, in building alliances with these family caregivers who are providing all of this unpaid labor that's so important. What I see are ongoing systemic obstacles to building these good working relationships between the mental health system and family caregivers for these illnesses. So let's look at what we have instead. We have inadequate public education about severe mental illnesses. You might have known, or might not have known, that in May, in fact, there was Mental Illness Awareness Week. And this has been going on for quite some time. It's organized by the Canadian Alliance on Mental Illness and Mental Health. And I am waiting to hear anything that could educate the public about the illnesses that we are dealing with. It certainly, I'm sure, accomplishes some things with its main and really, from what I can see, pretty much exclusive focus on finding 5 people who have dealt with some kind of mental health concern and overcome them. And in schizophrenia, this can sometimes be a problem because people really want to highlight the stars, the people who are doing spectacularly well, and that's supposed to make the rest of us feel really hopeful. It actually fills me with despair because it makes me feel like there's no room for my daughter and people like her who have needs that the system could handle in much better ways. So Mental Illness Awareness Week is linked to the website of the Canadian Alliance on Mental Illness and Mental Health, and I urge you to visit this website because it does tell us that its mission is to educate us all about mental illnesses. If you can find any information on that website about schizophrenia or bipolar disorder, be sure to let me know because I can't find any. And it's not negligence. There's reasons this lack of appropriate public education has been occurring. We need to change this. first step perhaps is calling attention to it. So we also need to pay attention to the inadequate education of many mental health professionals. I hope people in this room realize that there are programs across the country, including graduate programs like the University of British Columbia's Masters in Counseling Psychology, that regularly train people who become credentialed mental health clinicians. And these programs neither offer nor require any science-based information on psychotic disorders. Is there somebody that we could hold accountable for this? Really, it's an outrage when you think about it. It's fine that people are trained in psychodynamic theory. I trained in psychodynamic theory, and it's really interesting and can be very helpful in all kinds of situations. And it's very helpful in some situations where those clinicians look at a very disturbed person and think, I wonder what it was. Let's figure out what happened in your childhood that led to this problem. Psychodynamic theory is actually contraindicated in dealing with the most severe mental illnesses like schizophrenia. That we are not preparing clinicians to deal appropriately with this population has catastrophic results. One of the reasons I wrote my memoir was to call attention to what can happen if we, in our ignorance, send our family member off to get some support and help when things aren't looking right to somebody who has one of these degrees. People do real damage when they don't have the knowledge that they need. Real damage was done to my daughter because we do know that the duration of untreated psychosis, and that's what inappropriate treatment leads to, this duration of untreated psychosis leads to worse outcomes. It's bad for the brain. We need to get people out of psychosis quickly, and to do that, we need an adequately educated mental health force. I feel for all the mental health systems across the country who need to hire clinicians to fill all of these spots, and it's unfortunate if they didn't receive science-based training on these illnesses, but they need to do something about it. It's not acceptable. Let's think about what happens for these clinicians when they encounter a person with a severe mental illness. Not only do they not recognize it and send somebody to get appropriate treatment, they start to convey messages to someone who might be very paranoid. And paranoia is a really common aspect of schizophrenia and other psychotic disorders. They start to convey to these vulnerable people, let's think about what your parents may have done that led to these problems. The reality is that parents are going to make the biggest difference if they're willing to stay involved in what we all know is a really long, difficult journey. But early on, so many people with these illnesses make it less likely that parents will stay involved because the person with the illness, instead of immediately getting appropriate treatment, learning about their illness, and clinicians working to repair any damage that the illness might have done, instead, these people with these illnesses are moving further away from their families. It's hard to tell you how many times I've heard from other families that their family member at a local community mental health team, and we've been lucky not to have this problem, have been told, you know, you really need to think about becoming more independent. And really, the way to do it is to move out and become more independent. And we're talking about people with illnesses who aren't stable, who really need a lot of help to remember to take medications, to be encouraged to make doctor's appointments, to be encouraged to take appropriate steps to be involved in the evidence-based psychosocial rehab programs that might be available. So we need people to be getting really good advice, and people are not getting that good advice. The inadequate education of many mental health professionals also means that they are not in a position to provide appropriate psychoeducation for people about their own illnesses. And we do have some programs available. I'm sorry to tell you that many of them are really inadequate and in fact a problem. So luckily, in British Columbia, we have early psychosis intervention programs that really provide good psychoeducation about these illnesses to their clients. So in people emerging from psychosis, right away they're getting information they need about this is a brain disorder. They're also hearing about, and their families are also hearing about two key things that isn't information available in the widely used program put out by the Schizophrenia Society of Canada, which when a program's already prepared, it's very tempting for districts just to make use of it. These are two crucial things people with these illnesses need to learn about. They need to learn about anosognosia, which is the brain-based inability of people in profound psychosis to understand that they are ill. This is different than any psychological denial mechanism. And I'm going to be gradually setting up some competing paradigms here, viewpoints. Among the alternative movement, they can't yet accept that anosognosia, well accepted by neuroscientists, psychiatrists working with this population, families who see it. The alternative perspective, I have yet to see them accept the existence of this at all, because it gets to the heart of key political positions. It means that when somebody is really psychotic and really ill, telling everyone that the human rights position means that we must always listen to the person is not the moral high ground, it's the moral swamp, because it destines people to be lost in untreated psychosis. And we can see the results all around us. And I think with your Mental Health Act in Ontario, this might be more of a problem. We have a better mental health act. So people learn in good psychoeducation programs about anosognosia. For one thing, it means that all of this chaos that they've been experiencing, they can understand it. I saw this happen with my daughter and her friends who had good psychoeducation. Things that don't make sense can make sense, which is the illness made me think that way, as opposed to the counter-narrative, which is we need to explore all the delusions for their great psychological, emotional meaning, and that will lead to healing. We need to understand anosognosia for the brain-based symptom it is. The second thing that a really good psychoeducation program acknowledges and teaches its participants about are these predictable cognitive losses. I'm going to be talking in much greater depth about them later, but because I'm a teacher, and I always think it's good to mention things a few times, I'll just tell you that these predictable cognitive losses are things that even if nobody's told you about them, which they should have, and your family member, which they should have, you've probably seen them. They have to do with difficulties with working memory, short-term memory, sequencing, which are the steps that we go through to plan an action. These can be absolutely disrupted by these illnesses. Reasoning, judgment, problem solving, social skills, these are well-researched cognitive losses. And in British Columbia's early psychosis intervention programs, people learn about these, and they learn about some basic adaptation strategies. And I'm very grateful to Ivan Silver, because if you go to the Portico website, the website now has this very valuable BC psychosis toolkit there. It has a lot of useful information for you and for your family member. So, inadequate education of people about their illnesses. I do have to say just one more complaint about the broadly used program from the Schizophrenia Society of Canada. The only place I saw a family member represented was a mom figure saying, you know, I really came to understand that the choices, the decisions need to be left up to my family member. If I had let my daughter in the depths of psychosis make decisions, I don't think she would be alive anymore. We need to support families to make these difficult choices about involuntary treatment. And we need to help people who have become stabilized not to have more blame for their families, that their families persevered, but that they should be grateful their families may have persevered against great odds to get them the treatment that got them out of this hell, which is really what psychosis is, being cut off from reality. So, moving on with what we have instead of what we want, we have inadequate emergency services, and I know from talking to many people this is a problem. I did want to tell you about something that we do have in Vancouver, and because we have an annual family conference, which we also want to talk about a little bit later, more people from outside Vancouver have come to learn about Vancouver's CAR 87 and CAR 88. And this means that when there is a crisis in someone's home, you can call mental health emergency services, and you can get both a police officer and a psychiatric nurse to come to your home. And even when the system isn't totally overloaded, you can ask that the police officer comes in a uniform, if we think that's going to be more helpful, or comes in casual street clothes, if that's going to be more helpful, when they come to your house. And they will evaluate your family member. If your family member needs to go to the emergency room, as opposed to you going through all the difficulties of getting them there and waiting with a very psychotic person in an emergency room, they do this. So a really useful service. And I know more and more communities in British Columbia are trying to get this. What do we have instead? We have an inadequate number of acute and longer-term psychiatric beds. It's really important that before people with profoundly psychotic illnesses are discharged, they need to have their illness basically stabilized. And that often does not happen in a few days. But we have to persuade the people in charge of the purse strings that they will save money in the long run if they make sure that people spend the amount of time they need getting treated and getting stabilized before we send them out into the street. So we need these acute and longer-term psychiatric beds if we want people to have the best option to really recover in a meaningful way. We have inadequate supported housing, except you all have hope and a vision for the future because you have Home on the Hill, which is just an amazing model. Family-friendly supported housing. I'm trying to learn all I can about it to tell people in British Columbia. We have inadequate psychosocial rehabilitation programs. Some of them are good, but when you don't really acknowledge the reality of schizophrenia, and just so happy it's not mine because I realize I left it off. That might be my daughter calling me. We have some psychosocial rehabilitation programs that are really inappropriate. As a taxpayer, I don't think it's okay that our publicly funded healthcare system provides any psychosocial rehabilitation services that can make it more likely that somebody with a severe mental illness becomes more likely to drop out of treatment, medically based treatment that they need. And from what I can see, Ontario is leading the way in these kinds of services. And unfortunately, certainly in the 15 years that I've been involved in Vancouver, I see this happening more. But in British Columbia, we have a very powerful British Columbia Schizophrenia Society and North Shore Schizophrenia Society, and there's great resistance as these moves are made because sensible people, sensible healthcare leaders need to know that even though some people have usurped the right to represent all people with illnesses, my daughter never got her ballot to vote them into power to represent her interests, nor did her friends. And they don't agree that it's okay to deliver services that can lead to people stopping medical services they need. And this happens. So when you're not treating severe mental illnesses in the ways that can help people truly recover, what you end up with is a lot of people with untreated psychosis. And we can see across North America, and I think parts of Europe have this problem as well, more and more people with untreated psychosis ending up victimized, because you can't handle the world very well when you don't know the difference between what's real and what's not real. People end up easily being victimized. They end up homeless. I've seen this happen. We have a good mental health act, not perfectly implemented. So I have seen families who would have done everything to provide a home for their family member, but their family member was so psychotic they couldn't stay in the apartment that their families rented for them. So people can end up homeless, and increasingly in Canada, maybe not yet as bad as the US, incarcerated. This is what happens when we have untreated psychotic illnesses that really could be treated. So why don't we have what we need? What I want to suggest to you is that what we have are two competing belief systems, and I'm having them be represented by two key agencies. In the US, they have something we don't have in Canada. They have the US National Institute of Mental Health, which is the largest science-based research organization in the world working on severe mental illnesses. It didn't until recent decades. It was really trapped in the Freudian model, and there were big fights that went on among American psychiatrists to see if it was going to start to look at overwhelming evidence about, as we heard, the brain. And if you look at the National Institute of Mental Health website, which I encourage you to visit and read what they tell you, it's most recent and fabulously available head, and he's moved on to some other things, Thomas Insel, says schizophrenia, bipolar disorder, these are disorders of neural circuitry. These are brain disorders. These aren't disorders that come from trauma or bad parenting. Just right there, really clear. And in order to respond to them, we need science and evidence-based care. So NIMH, that's your friend. That's my big support. On the other side, we have the federal agency that US Congress, I'm an American Canadian, and it's not because of that that I'm going to keep referring to SAMHSA. It's because our family members are impacted by these beliefs and this federal agency. In the wake of the massive deinstitutionalization of people, and these giant asylums were often terrible, the U.S. Substance Abuse and Mental Health Services Administration, SAMHSA, was created to handle this most severe population that was coming out. Gradually, this organization, when you look at the historical accounts, kicked out all of its medical advisors. And this came out in recent congressional hearings for the last 3 years examining SAMHSA, because the U.S. knows it's got a big problem with untreated mental illness. So SAMHSA decided really what its mission should be is the mental wellness of the whole country. And also, until recently, it was headed by a human rights lawyer who clearly felt, and the organization federally felt, that you want to basically undermine any attempts to have involuntary treatment. So I'm in touch with American families on a regular basis and see them. People whose sons and daughters have much less severe illnesses than my daughter. My daughter was really at the worst, and I like to say that because somebody in the room might have that. And I want you to hang in there, because it can get better for most of us. I've lost that thought because I made a detour. So we've got SAMHSA that has had a belief that we need to work on everybody's mental illness. We need to ensure that nobody receives involuntary treatment and that it's a human rights violation, and that what we really want are a peer-delivered mental health system. And I'm a supporter of peer support workers. I'm not a supporter of the choices that Canada just made and that the US has made, which has hundreds of peer-delivered services. I remembered the thought I wanted to tell you. When I see these American families, I know that so many of their sons and daughters have illnesses that are less severe than what my daughter has. And once they became psychotic, they couldn't get them treated. And these were really resourceful people that are used to solving problems, used to being able to do whatever it took to help an ill family member. And their sons and daughters have ended up losing their lives in many cases, becoming homeless in many cases, and in so many cases, incarcerated. So SAMHSA wants to call everything a behavioral health problem. I actually, in this time of talking about stigma, find this to be incredibly stigmatizing language. In schools, we talk about behavior problems. Underlying that is a belief the person needs to learn to change their behavior. I think all of us here know that when you're dealing with a really psychotic person, the secret isn't to help them change their behavior. The secret is to get them out of psychosis, and usually there's a medically based way to do that. And SAMHSA also has continued to miseducate the public that all these problems come from emotional distress. And in the over-empowering of a well-funded alternative movement, we have just a whole other narrative that has developed about what's necessary. And the people who have really suffered are the people with the most severe mental illnesses. So I want to talk to you now about one thing that came out of these 3 years of this congressional subcommittee in the US, which was established in the wake of, if you can remember back, there's so many massacres, the Sandy Hook Elementary School massacre. And these House of Representative Congress people brought in the head of SAMHSA repeatedly for many grillings. Healthcare is handled federally in the US. We handle it provincially here. The big deal policies are federal. So they quickly learned that all of these medical advisors that SAMHSA originally had to have on its advisor boards had been pushed away, and that among the 500 federal employees that SAMHSA has creating policies and programs, there was not one psychiatrist. And this is the organization in charge of creating services for people with mental illnesses. So, SAMHSA was under a lot of scrutiny, and 2 years ago they hired a high-profile psychiatrist, Dr. Eleanor McCants-Katz, MD, PhD, an expert in addictions. SAMHSA does believe that addictions are real. Not so sure about mental illness and that that's a useful construct. Dr. Katz worked for them for 2 years, and then she quit. And about 2 months ago, she published an expose of SAMHSA in Psychiatric Times, a journal that I think lots of psychiatrists see and read. And she reveals an alternative approach to severe mental illnesses that is also increasingly popular in Canada. And so I urge you to just Google Canada, SAMHSA, and start to look at Canadian documents, Canadian meetings, Canadian guidelines for things that are very connected to SAMHSA. We're impacted by SAMHSA. I'm going to ask for your patience because I really want you to hear a couple of paragraphs of what Dr. McCants-Katz wrote. So it's not just me that's on some kind of weird trip about something called SAMHSA. There is a perceptible hostility towards psychiatric medicine, a resistance to addressing the treatment needs of those with serious mental illness, and a questioning by some at SAMHSA as to whether mental disorders even exist. For example, is psychosis just a different way of thinking for some experiencing stress? And I know that the Toronto area has many conferences, I think your tax dollars are funding them, to explore just this issue. Workforce issues, she goes on to say, focus in large part on the development of a peer workforce. This ideology purports that one can become a mental health professional by virtue of having a mental illness. Peer support can be an important resource for some, but it is not the answer to the treatment needs of the seriously mentally ill. If you go to the website that Kathy put on the poster, or Google Susan Inman Huffington Post, you can get to an archive of my articles. The second from the top one that they'll list is my article about peer support in Canada, because there now are new guidelines, and they just had a major convention, and it was really scary to me. This is really scary about what's occurring in the infrastructure of Canada. I support peer support. I think there are really very important, crucial roles that they can play for the people who receive services and for the people offering the services who have been through something really difficult and need to start to develop their skills again, their resume, so they can move on. I don't support the vision of peer support that was laid out in the new National Canadian Guidelines. These guidelines for the training of peer support have many things. Peers must learn about the history of the psychiatric survivor movement. There is absolutely no mention of peers learning anything about mental illnesses. And it's really the people with the most severe mental illnesses, like my daughter, who need peer support workers. And she's had some wonderful peer support workers, and we've been lucky about who she has had. I do not believe these powerful organizations have done right by the many people who want to become peer support workers by telling them, these are the things you need to know. We're not sure if mental illnesses are real. We don't want to offend anybody by saying they're real, or teaching you anything about them. It's not necessary. You are an expert based on your lived experience. That's a problem, and I see the negative consequences. Finally, Dr. McCants-Katz tells us, I left SAMHSA after 2 years. It became increasingly uncomfortable to be associated with an agency that, for the most part, refused to support evidence-based psychiatric treatment of mental disorders. It was also quite clear that the psychiatric perspective I brought, inclusive of assessment, diagnosis of mental disorders, utilization of evidence-based treatments, including psychotropic medication, and psychosocial interventions as integral parts of recovery, was a poor fit for this agency. This is the national agency providing services. You see why Congress has needed to step in. What Dr. McCants-Katz describes matters because it reveals the power of the alternative model of understanding and responding to psychotic illnesses like schizophrenia. This alternative view, I know I'm being repetitive, but my teacher's voice thinks, I'm going to say it again and again because I really hope that people will get this. This alternative view is impacting Canadian mental health care. We and groups like Home on the Hill are the only ones who can do anything about this. I don't see anybody else standing up to this. So what can we do? Well, we can call attention, identify and call attention to what is needed. And I think those of us who have ill family members and are dealing with the mental health system can see this all the time. We are the only ones that can say, I want my family member to receive services that will not undermine the belief they have in the medical treatment they are receiving. This is reasonable for us to ask for. We owe this to our family members. And we need to identify how we can work to get what is needed. So I want to call attention to something that I think is needed. I retired this year from, as I've mentioned, from 25 happy years of secondary school teaching. And it gave me the time I wanted to try to make something happen that I think should happen. And I was able to partner with the BC Schizophrenia Society and with Dr. John Gray, who's been a great friend to families and people with the most severe mental illnesses, to create something called the Promoting Cognitive Remediation Project. So part of my way of dealing with this project has many aspects to it and many things we're doing in British Columbia. And next week, tomorrow, I'm going to Ottawa because the Mental Health Commission has accepted this project as something they want to encourage, and I'm really grateful to them for this. We need to educate people about these losses. So, one thing that I'm calling attention to, we need to educate clients, who mostly aren't hearing about this, clinicians, many of whom have never heard about cognitive losses associated with these illnesses, and families about these well-researched cognitive losses that frequently accompany schizophrenia. 2 years ago, I visited a center at Columbia University that I'll be talking about in a minute, where they have state-of-the-art cognitive remediation and where they also have housed an annual cognitive remediation and psychiatry conference at Columbia. And this field has grown enormously. I'm saying such awful things. I want to see if I can say things to make us all feel better. You would have felt so good last week at this conference to see how widely implemented cognitive remediation programs are internationally. Japan has really picked it up. France has picked it up across the country. And the French prime mover made it clear that the driving force in implementing cognitive remediation programs has been families. That families putting pressure on their local mental health authorities saying, we want this. And often their family members aren't in a position to do messy advocacy. That's what's made it happen. And they're even using it in France for incarcerated people. And they've even created what looks to me like the state-of-the-art training program, because of course expensive staff training is an issue, but there's really ways to deal with this. If you want to get into that in questions and answers later. So across New York State, the Office of Mental Health Services in New York State, not that there's not a million things wrong with things in the US, it's standard services, cognitive remediation. For people, families that go to NAMI, the National Alliance on Mental Illness, regardless of whatever problems they have, they really have supported cognitive remediation. In a particular program that they've supported, cognitive enhancement therapy, and I think I have that website up here, that is a 44-week program, but the results are pretty amazing because it is now an evidence-based practice. And I could watch year after year and see families in different communities, there's 1,100 NAMI chapters in the US, have advocated their mental health service providers to bring in cognitive remediation. And we all benefit from it. Illnesses that aren't treated well are expensive for the whole society. It's not just us trying to get what's best for our family member. So we need promotion of these evidence-based cognitive adaptation and cognitive remediation programs. Just to explain, cognitive adaptation, and you'll find a lot of really useful things about that in the BC Psychosis Toolkit, are things that you're not so much focusing on changing somebody's brain as just making life easier, because it's hard with these cognitive losses. Things like checklists, alarms, signs, increasingly technological aids, so that there are things that you can do to adapt the environment that can help somebody manage it better. Cognitive remediation really works on helping restore, in this era of neuroplasticity, certain kinds of brain functioning that have been lost. And there's some really good research about it. So these losses, mentioned them earlier, have been very well researched. Just Google them, cognitive problems, cognitive losses. NIMH, they've been the leader in promoting this research, and difficulties with working short-term memory, attention, sequencing, problem-solving, judgment, and social skills. The impact of losses, NIMH states that cognitive losses are the biggest factor, in the ongoing disability of people with schizophrenia for people who are treated. And most people, not everyone, who have a psychotic illness can respond to medication positively. Not that there aren't difficult side effects, but most people can get out of psychosis. And when people are stable, then what is it that's impacting them moving forward? Well, these are well-known cognitive losses, and for many people, like my daughter, the cognitive losses are the prodrome to the arrival of full-on schizophrenia. So that we were seeing their teachers that didn't know any better, their therapists that didn't know any better. We were seeing these cognitive losses and had no understanding of what they could possibly mean. We need better mental illness literacy. So there's a variety of cognitive remediation programs. The best programs combine computer training with more comprehensive services. And there are two commercially, more than two, but two main ones, commercially available programs that NIMH helped fund in their early stages. You can buy them and do them on your computer. One is the POSIT program, which I think has been used in a number of geriatric settings. and one is Lumosity, which might keep having advertisements. It might just be my email that knows I'm interested, and somehow all the surrounding things are Lumosity. So my daughter has done both. Everybody figures out solutions that make sense for you. I paid my daughter $5 every time she did it, and she did it on a daily basis. And she was really happy to be earning some money, and I was happier for her to do. I'm very happy for her to do this. And just want to say that one of the things that she would say repeatedly after 15-minute or half-hour session from either of these programs was, my brain feels so much clearer. That matters. But the state of the art is much bigger than that. And I won't have time to go into all of this. So the big point is we need to make these remediation programs available across Canada for people who need them. And this must be understood as essential for achieving the best possible recovery. We're hearing a lot about one version of recovery, especially with this part. Well, key number one, person must choose. I think we have to assert, as family caregivers, that's what we're trying to get at. We want our family member to recover, but we want services that make sense and make it possible that they can manage the world better when we die. Cognitive remediation. I just want to show you some treasures in your myth, because really I've just been saying, maybe we've moved to the better part. So, about 2 months ago this book came out, Cognitive Remediation to Improve Functional Outcomes, edited by Dr. Alice Medelia from Columbia University, the person that started this now almost 20 years of major focus for international research on cognitive remediation. And the co-editor is a Canadian. Dr. Christopher Bowie is at Queen's, and he actually was going to come tonight, but it ended up being the night that his son has a concert. And I understood he needed to go to his son's concert. But this is a really useful book. It just gives you a sense of where the field is at. And I know from Dr. Bowie that he knows about you, he's interested, he would come and talk to you, and if you do end up ever having a family conference, I just heard him speak in New York. He is really good at what he does. I think you should get him to come. So this is a really important website. I'm going to give this PowerPoint to Kathy, and she can do what she wants with it. So there are issues about training. In order to spread out cognitive remediation across New York State, they did have to deal with the issue of training staff. And this isn't something that can be a peer-delivered program. It's complicated. I mean, I think it's complicated. And I was a teacher for a long time and thought I knew how to do things, but I really, every day is a sense of, why haven't I done better at this? But she created, and Columbia University created, a free training program for staff to implement this program. You have access to it. That's the website to get to it. It's 3 videos, and you'll just have, for many people, I think, an eye-opening experience. I think it's really useful. This is a little bit more about this conference that I just attended and how these programs are developing in other places in the world to hopefully persuade you to join me in saying, why can't we have them in Canada? And New York State put out a really useful free handbook that you can just click on. Dealing with cognitive dysfunction associated with psychiatric disabilities, a handbook for families and friends of individuals with psychiatric disorders. Really useful. I can't find this information on any other websites for Canada, for us learning about things. And the conference, here are some more useful links. This first article is just a good overview of the field, but there are many now. And I included these 2 about with NIMH links, just to give credit. This is who we need to be grateful for pushing the needs of our family members. Cognitive enhancement therapy is that program that NAMI has pursued, is evidence-based. And this is an article I wrote 2 years ago, and of everything I've ever written for Huffington, it's gotten the biggest response. When we do online journalism, we do look at, because we know our editors look at, likes. So this article has 5,000 likes, and what was really exciting for me is how many families contacted me. And these were families often who had learned a lot, felt they had learned a lot about mental illness, but had never been told about these cognitive losses. You may not know, so I'm sorry to give you more bad news, but there's endless research showing how every time there's a relapse in your family, it's your fault. You're doing something wrong, and they really want to help you overcome something called expressed emotion, or your lack of support for the recovery process or something. I think we can safely say all of that research is negated by the fact that nobody had ever told these families about these cognitive losses. So here we are as family members, having raised our children, and we're seeing a lot of behavior that in earlier years we might have thought about, well, that's so irresponsible. Why didn't they pass on this message? Why did they not keep track of where the keys are, or the phones are, or they've lost another umbrella, whatever it is. You know, families label this as irresponsible because nobody's ever told them. Actually, the neuroscience community is known for a long time. Families, nobody told you. This is absolutely predictable in schizophrenia. This is very common, these cognitive losses. And what families told me is that once somebody told them about this, of course it changes how we respond to these behaviors, because these are not willful. This is part of their illness, and we have to learn to approach them differently. So how can we work to get what's needed? We can educate ourselves. I do recommend the BCSS website, and I want to say that for years that's been the one place where I have seen a lot of literature about cognitive losses and the need for cognitive remediation. The NIM website, Treatment Advocacy Center, which wants people not to be left in untreated psychosis. Mental Illness Policy, a very important organization for understanding what's going on the political level, all kinds of educational events. And family education is really important. Ontario really scares me because you have a problem that we don't yet have in British Columbia, but Ontario is a leader in many things. You now have many government-funded, taxpayer-funded, healthcare-funded programs that call themselves family education programs that really are for the alternative viewpoint. So when I look at their websites, look at their curriculum, they want you, first of all, to try to figure out what you did to wound your family member that they ended up with so much mental distress, because often they don't recognize mental illness. They want you to know you must stop undermining your family members' growth and independence. Their decisions must always come from them. And do not, they wouldn't say encourage, they would say don't nag them about medications, going to these psychiatrists with their ways of thinking about things. That's for the person to choose. I think many of us know if we hadn't done that, the results would have been disastrous. So to get government funding going into these programs, training people in families in behaviors that will lead to worse outcomes, I'm terrified. And I don't want it to come to British Columbia. So how can we work to get what's needed? You can volunteer with the local mental health system when there's an opportunity for family representation. The Mental Health Commission of Canada did a very useful document about guidelines for increasing family involvement. Kathy McNaughey, I think she refers to it every time she writes any letters, any document I see. Really important, she wants people to know the Mental Health Commission of Canada says families should be involved in the planning of services and evaluation of services. Let me know if it happens here. It's we're pretty early on in Vancouver Coastal Health, although there is some progress. And cognitive remediation won't happen without families. You can get to know your local government officials, which you guys are really good at, and it's pretty wonderful. The way people have come here tonight, it's spectacular. You can comment online from the family caregiver perspective. I think Marvin and I can both tell you from, well, he's not as wounded as I've been, that when you write articles from the perspective we have, you will be attacked. And we always want more families to keep sending the messages that need to be sent out. You can write op-eds, you can build relationships with journalists, so we have more Kim Zarzurs in our communities, and you can do what you're doing, which is to build our own educated, supportive communities. And to me, the work of Home on the Hill is a model for the future. So thank you very much.